So without further ado, I would like to introduce the first speaker, who is Dr. Jonathan Choo, who is my colleague and friend. Jonathan is a senior consultant cardiologist in KK Women's and Children's Hospital. He is also the clinical lead of the Fetal Cardiac Program and the Inherited Cardiac Disease Program in the hospital. He's also the current head of the cardiology service in KK Women's and Children's Hospital. His research interests are in the areas of vascular biology, Kawasaki disease, developmental biology, and in preventive pediatric cardiology. He is also active teaching cardiac embryology at the Duke NUS Graduate Medical School. And he's also a member of our hospital's Clinical Ethics Committee and a member of the National Organ Transplantation Unit Ethics Committee. And also have been teaching medical ethics and is very active in the Singapore Medical Association Center of Medical Ethics and Professionalism. So Jonathan is going to talk about the ethics of fetal interventions and fetal surgery.
Thank you very much, Mio, for that kind introduction. Thank you, the organizers, for this invitation to just share a bit about the current science and the ethics with respect to fetal intervention and surgery. With respect to disclosures, I've got no financial disclosures, but I think in an ethical conference and an ethics conference, it's important that you understand the lenses in which I see the world. And so therefore, I'm a fetal cardiologist and a pediatric cardiologist. And we take care of children or fetuses with heart conditions. And with respect to perhaps ethical positions, when push comes to shove, I'm probably a bit more like Captain America than Iron Man, but we can leave that to a bit later during the discussions, and maybe during lunch we can talk a bit more about that. So with respect to fetal diagnosis and intervention, there have been rapid advances in ultrasound technologies, genetic technologies, and fetal MRI over the last 60 years. And people have, thought about this move of advancement as potentially a Janus phase, because there is a risk that we will make a diagnosis and the pregnancy is terminated. But more recently, there has been a possibility of fetal intervention, and that's probably in the last 30 years or so. And so I was wondering, where did this talk come from? And, over the last 2 years, there have been, more advice from the MOH, and this is perhaps where it, came from. In January 2021, there was an advice or circular from the MOH Singapore on the requirements of clinical ethics committees. And with this circular, there was 2 schedules of procedures that required clinical ethics committee considerations, and of which, whilst fetal intervention is not one of these 9 procedures, in the frequently asked questions, point 3, there was something said about fetal intervention. Should fetal intervention be referred for CEC consideration and review? And the answer was yes, you may choose to do so. And I guess the question is, what are the ethical principles in which we can use to guide us evaluate fetal interventions and surgeries? And so there's actually a very broad scope with respect to fetal intervention. There are transplacental medical therapies, there are fetal procedural interventions, fetal surgeries. And because of this broad scope, I just wish to just focus on the ethics of fetal aortic stenosis as an example, and fetal aortic valvuloplasty. When we think about fetal intervention, there are some basic decision-making points. Now, first of all, are we certain of the diagnosis? Is the ultrasound accurate? Is the MRI accurate? Do we know the natural history? Have we done enough studies? What is the evidence? And do we have a means of intervention? What are the risks? What are the benefits to both the mother as well as the fetus? And as we layer over these thoughts, the ethical issues, we think then, is this procedure experimental or clinical? And what I mean by this is if these procedures have moved beyond the point of equipoise. And then we think about issues of patient autonomy and procedural standards of disclosure. We also need to reflect within ourselves and ask ourselves whether the medical team is competent in doing these procedures and what are the standards of care. And finally, who decides? Is it the mother, the family, or physicians such as the CEC? Now, fetal aortic stenosis, as you might know in pediatrics, aortic stenosis is the narrowing of the aortic valve. And in fetal aortic stenosis, there's a risk of progression to hypoplastic left heart syndrome. All around the world, the average survival of hypoplastic left heart syndrome is about 60% at 5 years. And this is notwithstanding the fact that there are great centers and going about 80 to 90% survivability at 5 years, but overall about 60%. And fetal valvuloplasty for the aortic valve provides a means to convert about 60% to biventricular repair. And this is work done with the initial studies from Boston Children's Hospital and subsequently with the fetal cardiac intervention registry. No, but these centers are, these results are with good centers. And at present, we do not offer this therapy in Singapore. More about this later, and we can discuss at the panel discussion. So what is this disease that we are talking about? It's different from pediatric or neonatal aortic stenosis. Now, this is one of my patients presenting at 22 weeks gestation, with an obstetric screening scan, picking up aortic stenosis and analyzing across the aortic valve. And I've just shown you the 4-chamber views. And you can see that as the pregnancy progressed from 22 weeks gestation all the way to 36 weeks gestation, the fetal left ventricle, whilst being reasonably sized at 22 weeks, has become hypoplastic and poorly contractile at 36 weeks. And that substrate at 36 weeks would then be hypoplastic left heart syndrome. And with all its attendant risk of multi-stage surgery, such as the Fontan procedure. Well, as we look at fetal aortic stenosis, we have come to the conclusion that it is the dilated left ventricle and poorly contractile left ventricle, that really runs the risk of subsequent development of hypoplastic left heart syndrome. And this is early work done as far back as 1997 out of Evelina Children's Hospital. And you see that, as the pregnancy progresses, whilst the ventricles start off dilated early on in gestation, later on towards term, these ventricles become small and hypoplastic. So the therapeutic aim, therefore, is to prevent the progression of fetal aortic stenosis to hypoplastic left heart syndrome. And the case selection criteria is specific to the fetus. Now, in the West, we talk about acorns and oak trees, and in Singapore, we don't see that. So, I would think it would be coconuts and coconut trees, but I think you get my drift. So, coconuts and coconut trees are very different entities. And as we think about the fetal morphology of aortic valve stenosis, we're thinking of how do we change the natural history and reduce the subsequent risk. And this is what we do. It is a complex procedure. Now, this is a heart with fetal aortic stenosis. You can see that thickened valve there that aligning across the aortic valve. And when a case is chosen correctly, and of course, the mother consents, then as a procedure, what happens is that we will need to keep the fetus still in utero, and then there is a need to puncture the maternal abdomen across the amniotic cavity through the fetal chest into the left ventricle, to pass a wire across the left ventricle, across the aortic valve, and to put a balloon across that, and to inflate that balloon, and then to withdraw everything. And as you withdraw, you suck back to reduce the risk of hemopericardium, and sometimes you may need to give a shot of adrenaline just to kickstart the heart. So that's how complex the procedure is, and potentially it is controversial as well. But really, if you look at the evidence, in 2014, this is from fetal cardiac guidelines from the American Heart Association, Donofrio et al., and you see that actually fetal cardiac intervention for aortic valve stenosis to prevent evolving hypoplastic left heart syndrome has a class 2B sort of treatment effect and a level B of evidence. So therefore, it would be reasonable in the right centers, from the perspective of science, to offer such procedures. So going through the theoretical risks and complications again, there's a maternal risk and there's a fetal risk. The maternal risk of potential GA, a potential risk of scar, and the risk to future pregnancies if, for example, we have to do this as an open procedure. There's, of course, a risk of fetal death, and around the world, the cohorts would be about 10 to 20%. And the long-term sequelae is held in balance, in the sense that what is that effect or outcome that we're trying to achieve, and what potentially do we do the in-betweens where the procedure might not be that successful. Fortunately, when we look at the registries, we find that there have been no serious maternal complications, in all these procedures. So that has been reassuring thus far, but I think we need to think deeply and widely about these considerations. And how wide do we go? From the Fetal Cardiac Society's perspective, we have put together a fetal cardiac intervention registry. And because these procedures are so few and far in between, it's important to have consolidated guidelines, consolidated procedural elements, as well as outcome results, for these procedures. And these are the centers which are included in the fetal intervention registry. And as you see, there are hardly any centers in this part of the world. And so if you want to look at the website, you can look onto this website, and it details the aims and the reasons why the International Fetal Cardiac Intervention Registry exists. So as we look at the procedure again, we ask ourselves, who decides? And I would argue that the mother is the primary decision maker. The father, perhaps, to be a bit provocative, I might want to evoke a relational perspective to this, and I ask myself, could this be an issue of relational autonomy? And of course, in this part of the world, family comes into play, and arguably that is, sometimes difficult, but really we cannot remove the nuclear family, the person from the nuclear family, and the nuclear family from the extended family, and very often in this part of the world. And is it the physician who decides? Obviously the fetus, will not be able to decide or to express his or her wishes. Now, as we look at the ethics, I really want to center on this slide and, to think about this concept of fetus as a patient. And, this is a contested concept. Traditionally, from the ethical frameworks that we use in fetal medicine, we think of it as fetal rights versus maternal rights. But, I don't think this is really useful because it can become a zero-sum game, when push comes to shove. Rather, I'd like to propose that, we think of it as fetal rights and maternal responsibility. And as we look at, the Declaration of Human Rights, if we look, you can look at this paper and look at the articles itself. The wording for the Human Rights Declaration would be all human beings are born free and equal in dignity and rights. And significantly, the word born was used intentionally in this wording. So I think, from the rights perspective, the fetus has no rights under the Universal Declaration of Human Rights. But many of us would agree that there is a moral obligation to care for the fetus. And this moral obligation, I would argue, would be greater, increasingly greater, as the fetus becomes capable of independent existence outside the womb. And I think, therefore, it is good to think of it as a maternal obligation to take care of the fetus, and this obligation then extends from fetal life to neonatal life and perhaps into pediatric life as well. And there's good reason to seek the best outcome for the fetus, particularly if beyond the age of viability and from the medical perspective. So is fetal aortic valvuloplasty ethically justifiable? I would argue that in principle, yes. Mother remains the primary decision maker. Procedures should be performed in the best centers, and we should support the decision of the mother. Centers and cases should be enrolled in registries to track evolving technical aspects, outcomes, and complications of such fetal procedures. But we also have to think about the broader issues from the service perspective. It is multidisciplinary, it is highly resource intensive. Do we have the procedural capability to manage sequelae, for example, able to do a Ross procedure early in life? And the issue of distributive justice and accessibility to care. As you can see, many centers in this part of the world do not have access to fetal cardiac intervention. So in conclusion, the fetal medicine community is building the evidence base for fetal intervention and surgery. Fetal cardiac intervention and surgery are ethically justifiable, I would argue, if the following conditions are fulfilled: an overall positive effect on the natural history, that's beneficence, a minimal harm to mother and fetus, that's non-maleficence, procedural consent being appropriately obtained, that's autonomous decision-making, and particularly performed under the appropriate governance, issues of distributive justice. Thank you very much for your attention.